Hey everyone, this is Art Beauty Podcast, where we tell the real truth about the fake shit. We do this unbranded, unsponsored, and really we're unafraid to ask all of the questions that we know that you want to know at home. Today, my very special guest is Dr. Adam Kolker. He is a double board certified plastic surgeon, and are you ready for this? Because you guys have heard me talking about it for a while. He is the man that I am going to get the ladies done. Yep, I'm taking the plunge and I'm getting a breast augmentation and lift. Dr. Kolker, thank you so much for being here today.
It's a great pleasure to be with you, Amber. I'm looking forward to it.
Now, I want to be real. We keep it real here. So just right off the top, I'm paying full price for this, and we'll touch on that a little bit later, but I want people to know there's nothing about this that isn't honest and real. So many times we do things on this podcast, and I'm always advising people if they're going to do something, do their research, look into this, ask questions. And even though this is what I do, when I found that it was time to do it for myself, a lot of things came up. So I'm so glad that you're here. So I'm having a breast augmentation and a lift. And a little backstory on that: when I was, let's say, 13 years old and hit puberty, the summer between 6th and 7th grade, I went from A cup or no cup to a full C very quickly. And by the time I was in my 20s, I was a D, double D. So people are kind of wondering now, like, why am I doing this? And right off the top, I'm going to tell you, it's because I love my boobs. I love the way they look. I love the way I love the way that they look. But being 40 now, they don't have that perk without being in a bra. So I found Dr. Kolker, and this is something that we can fix, correct?
It surely is. So, just kudos, Amber, as well, to start with that, that nice conflict of interest disclaimer with that out of the way. There's one thing that everybody has to remember is that gravity always wins. And what ultimately happens is if everything is looking wonderful in 20s, terrific, but there's so many forces of nature that are at play. One of them, which we can never get away from, is genetics. Certainly, there are certain things that are in our genes that really predetermine to some degree a lot of things about our personal health in terms of our shape as we age, in terms of skin tone and texture, et cetera. And when we're talking about the breast, obviously, there's a certain amount of weight to them that over time, the gravitational effects are going to come to bear on them. So another thing that also people need to understand is that it's not only genetics. Lifestyle is incredibly important. Right. Eating healthy, getting plenty of rest. And when it comes to maintaining breast position or shape over time, wearing a good bra really helps. But there's only so much you can do because there's always a natural aging process where there's a certain amount of collagen and elastin that's in our skin. There's a certain amount of collagen and elastin that's in the supportive tissues, meaning the superficial fascia, which are almost like an internal bra that maintains support, that too tend to become a little bit more lax over time. So these are things that are fixable, meaning that there are certain things at the cellular level that we can't change, but architecturally or structurally or sculpturally, we can make improvements as issues tend to come up.
And now we talk on this podcast a lot about non-invasive procedures that you can do. But when it comes to lifting the breast and augmenting the breast, there's really not much you can do in the quote unquote non-invasive way. You're really looking at breast augmentation, correct?
To some degree, yes. And anytime we do any treatment, we always think about a ladder of least invasive to most invasive. And you never want to go directly to the top rung of the ladder. You always entertain what you can do that is A, the safest, and B, sort of the least invasive with the least downtime to achieve, to get from A to B, to achieve the goals that you're striving to achieve. And when we talk about breast enhancement, there are so many different sizes, shapes, etc., desires that that people will that will either present with or have, and you just have to make sure that you always that you always focus on what the least amount of invasiveness is.
Sure.
So, to your point, Amber, is there something that you can do to the breast that is totally non-surgical? And the answer is not really, meaning
No.
external energy modalities simply don't work. Now, as you move up the ladder, is there something that you can do to the breast that is minimally invasive, that doesn't involve incisions or seams or scars or restoring volume? And there are a few things that are actually out there. Number one is something called body tight, which is radiofrequency assisted lipectomy.
Right.
And I think it's important just to touch on that more for academic purposes, because the one thing that I just need to be very clear about with you and with anyone who's listening is there really is a very, very small slice of the pie, a very, very small subset of the population that would be interested in a breast lift that might be a candidate. Because anyone that has any real significant loss of volume, anyone that has real significant droop, and droop is a word that we use, which is more a lay term in medicine and surgery, we call it ptosis, Ptosis, and there are different degrees of ptosis. And they go from 1 to 3, mild, moderate, and severe. And mild is where the nipple position in the breast settles down just a little bit below the inframammary fold, which is the crease beneath the breast. And then as you go to grade 3, which is the most severe, it's when the nipple and the breast skin sags more considerably. There also is another form of ptosis that we call pseudotosis, which is almost ptosis, where the nipple position is up a bit above the inframammary fold or the crease, but some of the skin is more slack and sags down below.
Right.
And when we talk about the minimally invasive, meaning something like radiofrequency, what we find with radiofrequency assisted lipectomy, RFAL is the acronym. The company, has a trade name for the device called Body Tight. And there is some applicability, but very little, because it tightens a little bit. So you can see a little bit of tightening, but these are really reserved for people that are either pseudototic, meaning just a very small amount of ptosis, or the very mildest form. Anyone who has more significant deflation or droop is going to need something surgical.
Yeah. And let's be honest, they're not down to my knees yet, but I'm hoping that, by starting now, we talk a lot on this podcast about prejuvenation. And I'm hoping that sort of too, by getting a lift now, that, later down the road, they'll continue to be maintained well. And I also know the one thing you told me when I came in there, this will be my first breast surgery, but it won't be my last, because they're only good 10 years?
So it's an excellent point. I'm glad that one sank in. So the main thing to bear in mind is when we're talking about any implant-based surgery, and when we're talking about any surgery that is lifting against gravity, there are two kind of separate entities that can be combined. When we're talking about an implant-based surgery, implants are wonderful, FDA-approved devices. They are man-made. They will not last forever. And as soft and wonderful as they will be, they do need maintenance and surveillance. And at some point in every woman's future that has an implant, there will be the need for removal and replacement. And how frequently does that need to be done? And 10 years is a point where the antenna need to go up, and you need to start being a little bit more mindful about it. Does it mean that everyone needs another surgery at 10 years? It does not. So all comers, if you look at all women who have a breast implant-based surgery, breast augmentation, mastopexy, which is the combination of a breast enlargement with an implant and a lift. At 10 years, about 1 in 4 women, 25%, will need another surgery. And that slope going from the day of surgery out to the 10-year point tends to be relatively smooth and steady. And when you get to 10 years, it does tend to change a bit. The slope does increase. And by about 15 years, the number is about 50%. And by 20 years, it goes up to 80 or 85% or thereabouts. So it's not inconceivable that breast implants, if everything is looking wonderful, it's soft and balanced, and there hasn't been a significant change in shape or size or position of the breast over the course of a decade, do the appropriate surveillance, and then just continue to follow. And as as you get further down the line, you can kick the can down the road to a point. And the surveillance part, I think it's important to touch on this as well. There are two main types of implant, and implants obviously are used to do several things. One of them is to enhance size, meaning if somebody's a B cup and wants to be a C cup, an implant is ideal. If someone wants to maintain roughly the same size, but just accentuate more upper pole fullness, an implant is ideal. The types of implants that we have available in 2020 are saline and silicone. And there are a few different varieties and a few different manufacturers, but saline implants will tell you if they leak because you look down and one breast just gets smaller. Silicone implants will not.
I'm going to back us up a little bit. So we're talking about, implants. And one of the things that I want to make sure we hit on is just safety. Because I remember like in the 90s, they recalled silicone breast implants, right? They put a moratorium on it that they couldn't be used.
That's exactly right.
Are they safe now?
Let's talk about that. So the short answer is yes. I'll put an asterisk there because it bears a little bit of explanation or clarification on what safety really means. So to the end that will they last forever? No, something that they will need to be changed. But you brought up a good point that, there has been a sordid history, in the breast implant space, that in the early 90s, there was a moratorium that was placed on the insertion of silicone implants. And these are early generation, first and second generation implants that were filled with a silicone oil. And that's not the type of implant that we use today. So these are early silicone implants that were not the gel type implants. They were silicone oil filled implants. And when they leaked, they were locally nasty, meaning that the oil would leak out and sometimes it would cause local irritation of the skin and soft tissues and create lumps and bumps and problems. But the problem
was it something, sorry to interrupt. Now, when you talked about the leaking, was it something that would then leak into your, into your body, into your bloodstream? Like, could it cause massive, massive, massive problems?
So yes and no. It would not cause massive, massive problems, but local problems were not uncommon. And one of the things that was clear is that when a silicone oil, meaning the older form of silicone implants, would leak, they would cause local reactions. But unfortunately, what people felt at the time, and there's no data that connected things then, and it's very, very sparse now. And we'll talk about that in terms of the newest generation of implants. But with the early generation implants, they thought that they caused everything from lupus to collagen vascular disease to connective tissue disorder to fibromyalgia to Sjogren's to autoimmune issues of any shape, size, color, stripe, etc. And it turns out that back then there was no actual causal association, but there wasn't enough data to disprove it. So the FDA said no silicone implants starting from the early 90s, and that stayed in place through November of 2006. So go ahead.
All right. So, and now that they're back, and I believe that I went into you and, I found you because if you want the best doctor in breasts, I mean, I asked around and your name came up time and time again. And I'm just saying that because I always tell people, you need to ask, you need to ask people around. And then when I went on your website and I saw your before and afters, every single one of them was really to my aesthetic. And when I went in for the appointment with you, I said, I don't want to come in and tell you what I think you need to hear. I want to tell you what I want in terms of, you reach a lot about like high profile and low profile and all of these terms that I think that people go in. Am I going to do a gummy bear? Am I going to do this? I went in and I said, here is what I want to look like at the end. What do you suggest?
Well, that's absolutely the best way to do it because there are so many nuances that, I think that there's a tremendous amount of information online. And I think that one of the things that's important to bear in mind is that the internet is a wonderful tool, but there is no filter. So you never really know what's appropriate for you. And I think that there are certain, there's to your point, there are so many different implant types. There are different implant manufacturers. There are different implant fills. There are different implant shells. There are different implant profiles and projections. And what exactly is appropriate for every individual. And I think that we get so used to, mining the internet for data and thinking that we're the experts about everything. And you really, in many cases, just have to actually defer to the expert, because, this is a learning curve for even the best of us. And we always strive for that, that holy grail, that perfection. But it takes a lot of experience and a lot of doing it to figure out exactly what's appropriate for every individual. So,
and when I went into you, I'm almost embarrassed to say this. I think what you were touching on before, there's something called breast implant illness, which I was not aware of. To be quite frank, I didn't want to research the dangers of breast implants because, and I have to put this in right now because my parents both listen to this and they're probably just dying right now thinking, what is she doing? But I read somewhere that there's 300,000 breast augmentations done in the United States a year.
That's correct.
I mean, so that makes it one of like the most popular cosmetic procedures.
It is from an actual surgical perspective, meaning that when you take out the non-surgicals, things like Botox and Juvederm and the injectable treatments, when you talk about just surgery, with the data that's collected by the American Society of Plastic Surgeons and the American Society for Aesthetic Plastic Surgery, breast augmentation has topped the list for the last number of years running. The number is in the low 300,000s, so just over 300,000 for breast augmentation. And when you add to that women who get breast implants also with breast reconstruction, which generally ranges from about 100,000 to 150,000 a year that choose breast implant-based surgeries, it's well over 400,000 women a year that do get breast implants. So going to your question about breast implant illness, I think it's important to talk about it. And I think that the jury is still out on it. And I think that it's important for, as we discussed when we chatted about this, it's important for every individual who's considering doing elective breast surgery with an implant to hear all of the risks and benefits of any procedure, and anything that's out there needs to be discussed in great detail. And the fact that breast implant illness is talked about, you need to hear about it. But I think it's also important to know that there is not a lot of data out there that connects the data points, meaning from a causal perspective, meaning implant in illness.
Sickness happens, sure.
Yeah, that's it. So, and the big question, is it SII? Is it silicone implant illness? Is it something that can happen with saline implants? And is it something that is just a matter of coincidence? And that's one of the things that, is also, worth considering, which is breast implant illness only happens to individuals who have breast implants. Breast implants tend only really to be done in women. Women tend to be somewhere in the neighborhood of 9 times more likely than men to develop autoimmune issues.
Sure.
So you say, well, is there really a causality between an implant and that X, Y, or Z autoimmune issue? Or is it something that just may be coincidental because over 400,000 women a year have implant surgery and they all happen to be women, and women tend to be more likely to develop some form of autoimmune issue? So again, there is no clear data on this. Our discipline is looking at this very carefully. Our societies are looking at this very carefully. The FDA is looking at this very carefully.
It'll probably be interesting too, because now, you said that the people who get breast implants are women. But recently now, I mean, we live in a wonderful, incredible time where, both genders and however you identify, I wonder if there'll be more data where, there are people who were born biologically male.
Correct.
Will, then add a little bit of insight to this. It's
an excellent point. And yeah, so the MTF, the male to female trans population, it's still, I want to say, it's in its relative infancy, meaning that we don't have a tremendous amount of data because the numbers are not there yet for an adequate comparison. But you're absolutely right. At some point, we will have enough data to make that, to at least try to make that comparison.
So going back to the 2 types of implants, now granted, you said there's many different manufacturers, but really what we're looking at is saline or silicone. Is there one that you prefer?
So it's an excellent question. I think they're both wonderful. And I think that there are advantages to each, and I think there are disadvantages to each. And I think that when we talk about breast augmentation, taking someone who likes their shape, they're an A cup, they want to be a B cup, they're a B cup, they want to be a C cup. When we're talking about augmentation mastopexy, meaning someone who either has lost volume or has noticed some change in shape or position or volume in certain areas of the breast that also needs some volume. When we're talking about someone who has a congenital breast deformity, something like constricted breast deformity or tuberous breast, or even reconstruction, my feeling is that of all of the choices that are made in all of these scenarios, that the implant choice itself may be the least consequential. I think that there are many more similarities between saline implants and silicone implants than there are differences. What I can tell you is that nationwide, silicone tends to be the much more commonly selected implant. It tends to range somewhere in the 85 to 90% range year after year. In terms of what American women will select, and collectively surgeons and patients choosing the implants. There has been a little bit of a pendulum swing back recently towards saline, partially because of the little bit of a scare that's out there with regard to the idea of breast implant illness. Because is it silicone? Is it any implant? Because we're not really sure, I think people have at least a gut feeling that saline at least sounds safer. So some are choosing it a little bit more commonly now, but I don't see any pressing safety reason to do it. The reasons that I think are appropriate in terms of making the choice between saline and silicone really function on two levels. And again, the differences are really quite slim or small. Silicone implants have a reputation of feeling and looking a tiny bit more natural, because the responsiveness of a silicone gel-filled implant compared to a saline-filled implant is, if you think about taking a Ziploc bag and filling it on one hand, if this is the saline category, this is silicone. If you fill a Ziploc bag with water, and if you fill a Ziploc bag with pudding or Jell-O, and you touch each of them, you're going to be able to feel the difference.
Yeah.
Now,
Yeah, my husband was there. He went with me to the appointment, and I said, well, what do you think? And he's like, you know what? I got it. And he's super, super, super supportive. And I brought him asking his opinion. He was like, I think the saline feels much, more real. It didn't feel like you were like touching a water balloon.
That's right, the silicone. So,
the silicone, sorry, felt more real than the saline. Thank you.
So silicone does have a little bit more of a natural responsiveness than the saline does. But remember, it also is a function of how much tissue is above it. Meaning, if you're taking someone who's got a fair amount of breast volume, that is, for example, doing an augmentation mastopexy, that has a reasonable amount of cover, so to speak, meaning breast tissue, subcutaneous tissue, which is that thin layer of fat beneath the skin, muscle, whatever you're putting it underneath, the difference becomes much, much less. Mm-hmm. But again, the advantage of silicone over saline, it has a more natural feel, that responsiveness, and it also is slightly less likely to ripple, meaning that the edge perceptibility of an implant with a silicone implant is a little bit different than a saline implant that tends to have a little bit more rippling. So those are really the main differences in terms of look and feel. So if you think about the advantage, disadvantage, silicone gets the nod in the touch and appearance category.
And I'm pretty sure that's like what we decided on for me, right? And the reason I'm saying I'm pretty sure is because I look at you, Dr. Kolker, like you wouldn't go and tell Michelangelo what paints to use. So I came to you and I said, you are the best of the best. And I really need to rely on your expertise, having done this for over 20 years. Let me know what you think is best.
That's great. Well, I could stay here all day listening to your compliments, Amber. Keep them coming. Thank you for saying so. But but that's absolutely right. But the one thing is, when, and I think that everybody is different in terms of how involved they want to be in making their choices. And one of the things that I think is the most important for me is that everyone makes an informed choice based on as much information as I can give them. So I think that when we talk about the difference between saline and silicone, there's a very gut level personal connection that, or aversion that they may have with one or another of the implant choices. And when we talk about the advantages of a saline implant, it really comes out to not safety per se, but with the need for surveillance or follow-up. And every woman needs to be up to date on mammography and or ultrasound and or exams with their GYN or their PMD, and just focus on breast health. But implants do need to be watched as well.
Yeah.
Saline implants need to be examined, certainly. But let's say, for example, we go to year 7 or year 17 or wherever it is down the line, and a saline implant leaks. You will know it, because assume somebody goes up a cup size with their implants, and then all of a sudden one of them leaks. You'll see it, because the body's going to absorb the saline water that comes out, and you'll know. You'll be a C
I know
cup
somebody
on one
who
side.
went up. Yep, who went up a couple sizes and woke up with one, and she had saline, and woke up with one deflated breast.
It, and very rapidly goes down. So that's one of the main advantages of saline over silicone, is that silicone, on the other hand, requires a little bit more surveillance. So when the FDA reapproved silicone gel implants for widespread use in November of 2006, they recommended that all women get a baseline MRI at 3 years,
right,
and every 2 years thereafter. And that's a lot of MRIs to do compared to a saline implant that requires none. It just requires the regular breast, the breast health.
And on that, it's something too, you want to also consider the cost of that, because MRIs may or may not be covered if you have insurance, and they're not inexpensive. So you have to really factor that into this.
That's exactly right. That's exactly right. Because they're not always covered by insurance. Not everybody has insurance to cover it. And the big question is, how frequently do MRIs really need to be done? And the 2006 guideline of the FDA still stands. They are strongly considering changing that baseline and pushing it out. The reason for that is because what we found is that the leaker deflation rate is incredibly small. And does it make sense, if we're talking about at 3 years in, something that is at or below 3% risk, to actually start an MRI process for the 97% that don't have any issue with the implant. Right. And and every implant manufacturer and implant type is a little bit different, but leak rates tend to be in the first 10 years, ranging somewhere in the neighborhood of 0.5% to about 1.5% per year, by and large, something in that neighborhood. And then, as I mentioned, the slope does start to change a little bit as the implants get a little bit older. So pushing the first MRI out is not unreasonable, but it's done on a case-by-case basis.
I'm going to bring this back to, again, because, when you're going through it yourself, there's just all of these things that you realize. And in all fairness, when I went and I was like, you know what, I want them perkier again. I want to feel, I've shared with people my experience with IVF that didn't work. And, as a woman, as somebody who loves my femininity and my body, I was like, you know what, I want to do something good for my body. And I want to give my sort of outer self, make it feel as good as I do inside, and get them, lifted and perky. But I had no idea what an investment this was going to be. Really, I didn't. One that I'm willing to make, and luckily in a position to, but I do want to reinforce that to people. You need to know that this isn't just a one and done.
Right. Well, I mean, the whole idea of the need for maintenance or surveillance, everybody needs to be focused on breast health. Yeah. And it does add a small piece, to the puzzle, so to speak, that there's one other thing to be mindful of going forward. But, just to reiterate what we talked about before, is that our hope is that it's 10 to 20 years that that the initial surgery will last, but you still have to be mindful even within that first 10 years.
I mean, come on, in 20 years, I'm going to want to have some more stuff done anyway. So, I mean, just tack it on.
Why not? Why not?
So, what about in terms of like placement? I hear a lot of things about under the muscle, above the muscle. Any thoughts on that you can share with us?
Yeah, absolutely. So there are advantages and disadvantages to each of those positions. So there are 4 main variables that we talk about with any breast enhancement procedure with implants. Number 1 is going to be the incision pattern. Number 2 is going to be the implant selection. Number 3 is going to be the muscle position. Number 4 is going to be the size of the implant that we ultimately choose and how we get there. So we talked a little bit about the implant selection. The muscle position is something that's also the subject of a little bit of controversy. Do you put the implant above the muscle? Do you put the implant below the muscle? And there are very good reasons to choose one or another depending upon the individual. What I can tell you is that the majority of women in my practice tend to be candidates, and I tend to recommend a little bit more commonly the placement of an implant below the muscle. And there are some considerable advantages to placing an implant below the muscle. One of them is that there is a tremendous amount of data over the years that has suggested that something called capsular contracture, which is a scar shell that forms around an implant, the capsular contracture rates are less when you put an implant below the muscle. So that's one very pressing safety-driven reason to choose an implant placed below the muscle. There's another one that's aesthetic as well. And what that means is if you think about an implant, the implants that we use now have a certain degree of roundness to them. And what I mean by round is if you put it flat on the table, it looks like a dome. It's round. If you stand it up on its side, any of these implants are actually going to allow that gel or saline to settle in the lower pole of the implant, having a little bit more flatness in the upper pole, but there's still a little bit of roundness in that area. By placing an implant below the muscle, so if you're looking at the body in profile, putting an implant below the muscle tends, any roundness or any fullness that's in the upper pole tends to be blunted by the muscle as well. So there's a big advantage to that. And what the advantage is it just makes breast over time tend to look more natural. And the reason for that is because if you were going to go take a drawing class and you were going to draw a breast in profile, you would not make a half circle as a breast. Right. You would use two geometric patterns. One of them is a triangle on a quarter circle so that there's more of a slope that comes down from the collarbone area down towards where the nipple resides, and then more curvature in the lower pole. By placing an implant below the muscle, it tends to accentuate that. Even if people are trying to push volume a little bit, maintaining something that's on the fuller end of the natural range where there may be a propensity to have a little bit more upper pole fullness, it can still look natural because there's that little bit of a blunting by placing the implant below the muscle. Go ahead.
Oh, yeah. And you know what? I just want to point out. So one of the things that I came in and I feel like I'm seeing more and more in what I'm reading, that there is this trend in breast augmentation to a quote unquote more natural.
Without a doubt.
There's also the people out there who want to look done. And we know this, the difference between West Coast and East Coast aesthetics and all over the world, there's different aesthetics. And you know, however you want them to look is how you want them to look. You do that. Exactly. But in terms of this more natural look, you recommend going under the muscle.
I do. And, you know, what I will tell you is I think that one thing you have to, I think you touched on it in terms of East Coast look and West Coast look. I think that, there are East Coast surgeons on the West Coast in terms of look, and there are West Coast surgeons on the East Coast. You'll find them anywhere. And I think that one of the things you have to, that you have to bear in mind is that every surgeon has their own compass that's based on their personal aesthetic, that's based on their experience, that's based on their, that's based on their interpretation of data. And one of the things that I can tell you is my compass, at least aesthetically, tends to point towards natural. It can be on the, more conservative end of natural. It can be on the fuller end of natural. But that's informed by a few things. One is natural just looks prettier. I want to say to me, and I think that for most people that would choose me as their surgeon, I think that there are certain people that are looking for a more West Coast look that may not necessarily choose me as their surgeon. But there's another added advantage, which is the bigger the implant, the bigger the problems. The more volume you put in, the more stretch of the skin, the more potential of an impact there is on the chest wall, the more potential droop or descent over time. The bigger implants are associated with a higher incidence of sensory change in the nipple and skin of the breast. You can go through a list of potential downsides that are associated with larger size implants. So not only is there an aesthetic advantage, A, to choosing the right size implant for the individual, B, putting it below the muscle to accentuate a natural look, but there's also a safety advantage to them as well.
I found it so overwhelming. When I came in, we sat down and one of the things that you asked was, okay, now after our consultation and you did measurements and we had this very thorough discussion, it was time to sort of look around and play with some implants. And you brought in these not the actual implants, but they're sizers, I guess, to put into the bra to
Exactly.
give her date. I found that I had a hard time with that because I'm already, as I said, I'm in the D family. This is a push-up bra, so it's definitely accentuating them. But how do people, I don't know, how do you go in and pick a size?
Yeah. So there are a lot of different data points that we use to figure it out for every individual, and that actually is one of the fun ones, because I think that you can really get a give a little bit of a sense to yourself by actually simulating the volume in a bra. But it doesn't always work. The reason for that is because, particularly for someone who's starting with a fuller breast size, is it doesn't always fit right, and you're not really sure where it's going to sit. And for someone like you,
there were so many giggles, by the way. And my husband was taking pictures. And I did try on it was like what would essentially be like a 500 cc. And it was like, hello, Dolly Parton.
That's exactly right. So that's one of the pieces of the puzzle, so to speak. So one of the many. So one of the most important things is, whenever I have an initial discussion with someone, and I usually try to do as deep a dive as I can into their goals and desires right up front, to really get a sense of where they're headed with this. What I tend to do is take that as my foundation and then marry that with the exam. And the examination that I do, and one of the things that you probably remember, is we measured you very, very carefully, where we use tape measures and calipers, and I get a sense of a number of things. We do a proper breast examination to make sure that there are no lumps or bumps or masses, that breast health is ideal. But I also need to get a sense of the elasticity of the skin. I need to get a sense of the density or sponginess of the breast tissue. And those measurements that I take really are very informative in terms of what fits just right. And what I tend to, feel is that you have to have a tremendous amount of respect for the biodimensions, meaning that the dimensions that are measured from an anatomic perspective, so that the final implant choice really is a perfect marriage between what it is that we choose and the individual's body. But the sizing exercise that you did is also, yes, it's a fun exercise to go through the process, but it also gives me a sense as well, because once I've done those measurements, after I've heard what an individual's desires are, I have a pretty clear idea about someone's range. I may not know the exact number, but I know for the most part that it may not be a 150. It may not be a 500. It's probably going to be somewhere in between as we get a little bit closer to the ideal number. But there is going to be a range there. And then what I like to find is that after someone does sizing exercises, if they come out of the room and they say, I love the 500, then I say, listen, we have to sit down and talk about this. It's not going to be a natural look. It's not going to be the appropriate implant. And if they choose a number that tends to be in the range that I've established, at least before the sizing exercises happen, perfect. So what that means is that's how we tend to focus in on what the ideal size choice is. The final decision is actually, go ahead.
Yeah, no, tell me what the final decision is.
The final decision I make in the operating room.
Yeah. I was just going to say, because I'm pretty sure I signed something that said at the end, it's up to you. And to be honest, I went in saying, hey, listen, if you have to do what's right. I am a little bit broader. Like I said,
that's right.
You can see in a bra, I've got boobs, and full admittance, I was like, if you're on the fence, like, do I go a little bit bigger or a little bit less? I was like, you can put a little bit more in there. Why not? Part of the reason, I want to get on this, because I came to originally because I wanted a perkier breast, and that involved having to do a lift. The reason that I decided to add an implant was not necessarily because I'm unhappy with my size, but by doing the lift, you mentioned that we would lose some of the fullness.
That's exactly right. So the way
I did not want to get smaller.
Yeah, no, absolutely. The way to think about that is, if you think about taking a bra, if you're wearing a D cup now and you take a B cup bra, it's not going to fit right. You'll put yourself in, you're going to pack yourself into it. There may be a little bit of skin or tissue that comes out on the side, and you'll push yourself into it as best you can. And then if you take a step back from the mirror and you look at yourself, you're going to end up looking smaller. So even if you have to remember that there are two main elements of the breast. There's what fills it, meaning the breast gland and the breast fat. And then there's what covers it, which is skin. And the skin is effectively like a bra, and you can really refer to it as a skin bra. And over time, when there's a little bit of slackness or droop that develops to the entire unit, meaning breast gland and fat and skin, there are a few things at play. One is that there's a little bit of a laxity within the breast itself internally, so that needs to be tightened up. And then the skin itself needs to be tailored the same way you would tailor a suit or a dress. And that's where the seams come into play. But to your point, yes, you will look a little bit smaller, because if you do make that skin bra smaller, you're making the breast more compact, you're tightening things up from the outside. Many women will see at least a small reduction in the overall size of their breast. How much is it? It's going to differ from one individual to another. Somebody who's got a much more dense breast may see a very small difference, maybe a quarter of a cup size, if that. Someone who's got a more spongy or less dense breast may see a more considerable size decrease. It may look as if, even though you don't remove 1 cc or 1 gram of breast tissue, then it may appear as if you've gone down a half a cup to a cup size. The other thing, too, that you need to think about with what we call an augmentation mastopexy is when we take the breast that settles down below the fold and we bring it back up to where it belongs, a lot of that is going to come back up into the upper pole and give you what we call upper pole fullness. But it's not always enough. And that's where the implant comes into play. So it's not necessarily to make the breast bigger per se. It's just to give that perkiness and fullness in the upper pole. So, and what I mean by upper pole and lower pole is, if you think about the breast, if you're looking at it as if it's a globe or a circle or a sphere, and you draw a line through the middle, which is the equator line, there's a southern hemisphere and a northern hemisphere, or a lower pole and an upper pole. So we usually refer to the poles of the breast. The lower pole, ideally, at least in terms of aesthetic ideals, you want there to be a reasonable amount of fullness in the lower pole. In the upper pole, it's on a case-by-case basis. It's very individual. So some people like a very concave or a very scooped out upper pole. Some people like it a little bit more full. And I think that when we're talking about a real accentuation of youthful fullness of the breast to make things look natural, proportional, perky, occasionally the lift alone is not enough. So that's where the implant comes into play.
So now, talking about the lift, I'm going to be doing what they call like the anchor, correct? Which is an incision under the breast fold, one that runs from the breast fold to the nipple and then around the nipple. Also, full disclosure, we're going to do a little lipo in the fat bra area.
Yes, we are.
Because I was in there and I was like, can we just throw this in there too while we're at it? But what is this recovery going to look like?
Yeah. So in terms of the incisions themselves on the outside, that is not the rate limiting step or the definer of recovery. They can be sore, but that's not something that's going to be the more uncomfortable part of the process. The discomfort is going to be akin to a breast augmentation, which is the placement of an implant behind the muscle. That's going to be the one part that is going to have the most impact on what you feel afterwards. And there is a degree of soreness. And what I can tell you is that probably 2 or 3 out of 10 women that have this type of procedure just have Tylenol afterwards, and that it's manageable. Others will need something a little bit stronger for the first few days, but it does not have that much to do with the lifting portion of it. And to your point about the incisions that are associated with the breast lift, everybody's different in terms of what they need. Right. So the degree of ptosis that we talked about, that grade 1 or grade 2 or grade 3, the more excess skin there is relative to the volume that you have afterwards is going to inform how much seam you require. So some people need just a circle, which is called a circumareolar mastopexy. Some people need a circle and a line, which people refer to as a lollipop lift or a lollipop mastopexy, which we call circumvertical, and vertical. And then there is the possibility of some adjustment in the inframammary fold when there's a little bit more skin excess, or the need to tighten that region. And interestingly enough, people have been talking a lot over the last number of years about short scar breast lift. And in actual fact, even people in my hands that need all of the incisions, the circle, the line, and the line in the crease beneath, It's all based on short scar technique, not the more old-fashioned, what we call a wise pattern reduction technique. We always start with the limited or the minimal incision pattern, then whatever skin is left that needs a little bit of tailoring, then we follow the trail and then figure out what's going to go away on its own, we don't need to remove, or what's not. And then we do. It's always better to take care of it in the initial surgery. And then talking about the liposuction of the arm area, that's something that's become very, very popular lately, because that area that tends to bulge just a little bit over a tank top or over a suit, it's very, very straightforward to at least remove a little bit of it. And I think that it's important to note that you can't remove it all, because we always talk about the relationship between skin and what's underneath. And if you're too aggressive with it, you can create a little bit of a deflated effect in that area. But that tends to be a trouble spot for a lot of women. And sometimes people do it just as an isolated procedure that are comfortable with their breast size and shape. But it's a really terrific adjunct or addition to breast enhancement surgery.
So, okay, I feel like we've gotten through all of like the tough stuff. Let's get a little bit fun here. In your opinion, do you think this is one of the most satisfying surgeries? Because I feel like even when I went on your site and saw some women with extreme ptosis, the afters are imagine that. What is that animal with the wolf's who eyes kind of pop out? These women were all so smoking hot afterwards.
That's great. Well, it's, to your point, I'm very lucky to be able to do what I do. I feel like I'm blessed every day because it functions on a few levels. One of them is breast aesthetics in particular, plastic surgery in general. But when you look at some of the complexities of breast enhancement, it really is a very unique sculptural, artistic, technical challenge. And it's incredibly gratifying to envision a result and be able to use the tools that I've acquired over the years and the experience that I have to really fine tune and meticulously get from point A to point B. But on the flip side of it, and I think this is actually the more important, is it's really life-changing for people. And some more than others. The ones that that I tend to see, there's a subset of the population that have what we call constricted breast deformity, where they're born with, and it can be droop. Sometimes it's ptosis in some form, but potentially on one side and an underdevelopment on the other side. That these can be tremendously life-changing. And the lessons that are learned from some more straightforward cases compared to the lessons that are learned from, the more challenging reconstructive cases, it obviously helps me to get people, to a really different place in their lives, because I think that self-perception is based on so many things, and all it takes is just shifting your perspective just a little bit. And sometimes, that kind of physical change is enough just to make people feel absolutely great about themselves.
We had a woman on here, a young woman who had tuberous breasts, and shared her entire history with us. And her life-changing, for her surgery was life-changing. I also had a girlfriend who was diagnosed very young with breast cancer and recently had a reconstructive surgery. And for her, she never had breasts. And then she was like, you know what, I'm going to do this for myself. And it's just been wonderful to see that sort of light, it's incredible. So thank you. And thank you for all the time that you've put in.
Listen, it's a labor of love. I love doing it every day, but when you look at it really carefully, I think that, when you go into medicine, I think that there are certain parts of medicine that are focused on increasing or prolonging the length of life, and that there are certain corners of it that are focused on improving the quality of life. And I think that I'm fortunate to be in that category, where I think that, and we look at this objectively as well, there are outcomes instruments that are used in academia, in medicine, that very, very carefully look at how people feel before a procedure and very, very objectively at different points afterwards, with very reproducible metrics, can look at how they feel after a surgical procedure. And almost uniformly, you see tremendous increases in self-perception, sexuality, quality of life, in the majority of these categories with this type of surgery.
Well, I cannot wait. I am so excited. Our surgery, let's see, is in 9 days from now. This will be airing the week of the surgery. It will be after my surgery. And I'm doing that because I don't want anybody to second guess anything that I'm doing. It's none of your business. I've made this decision and I'm in the best hands. Right. Before we go, one thing I want to ask you, because we've got listeners actually all over the world, in terms of picking a surgeon, what I did was I'm lucky because I get to talk to a lot of doctors, and a lot of the people that I speak to have been on this podcast. Your name came up quite a bit. Then I went on and then I saw your before and afters, and I was just like, every single one of them was great. And then full disclosure, you had some Yelp reviews from people that I went and privately messaged, and everybody was singing your praises. So I love it. Do you have a suggestion though for somebody who maybe isn't in the New York area? Because there's so many options, and to be quite honest, there's such a range in price from, is there any suggestions that you have for somebody to pick their surgeon?
No question. Well, first and foremost, I think that, as a foundation for this, you want to make sure that the surgeon that you choose is certified by the American Board of Plastic Surgery. And that should really be a prerequisite for this. And society membership, I think, is also an important part of this, because it really means that that the surgeon is maintaining CME credits, obviously continuing medical education, making sure that they're up to date with all of the current advances. Because one of the interesting things is the world of medicine and surgery, and plastic surgery in particular, in 2020 is very different than it was in 2010. And it was very different in 2010 than it was in 2000. So the surgeon that you choose has to have some maintenance of certification and level of academic interest. The other thing that you need to do is feel comfortable with your surgeon. So once you've gotten a sense from them, whether it's from friends that have seen that individual surgeon, he or she has a certain gallery that may appeal to you, then you meet the surgeon in person. And I think that there has to be some fundamental connection, because it really is, it's a team effort, and it's not a matter of doctor, patient, and patient being a widget moving through this process. It needs to be a situation where the patient is a person, and that person's wishes and desires and goals are heard. The surgeon needs to take a very, very careful look at the anatomy, and then sit down and go over everything from soup to nuts, from all of the upsides of a procedure and then all of the downsides of a procedure. And then make sure at the end of the process that there is a shared goal, that there's a commonality between the surgeon and the individual who chooses that surgeon. So I think that, to your point, it's difficult to do it, but I think that one of the important parts is listen to your gut. And I think that most people will figure it out in that way.
And we live in an incredible time, so don't be afraid to do the research. I brought my best friend in my world is my husband, and I brought him because I really just wanted to also, he's putting his wife into somebody's hands, and I thought it was important for him to meet you as well. And he was like, yes, he's great. And so thank you. You took wonderful time with us. You explained everything. Your staff has also been incredible. And I will tell people, when you're thinking about somebody, make sure you read the reviews about the office as well, because you're going to be dealing with the office team in general a lot more than you are with your surgeon. So kudos to your team there. They're phenomenal. And, listen, in terms of price, here's what I'm going to tell you. My dad always told me there's two things you don't want to save money on, and that is birth control and plastic surgery. So everybody has to do what's right for them. But,
that's it.
Right. It's your body. It's even more than a house or anything. It's what's worth investing in more than yourself.
That's right. Well, more often than not, you get what you pay for. So you always have to remember that. But you also have to remember too that New York City is always going to be at least a little bit different than the heartland. There are certain
Sure.
There are certain points that, are not just related to surgeon experience and expertise, but, I think that being comfortable with your doctor is probably the most important thing. And that's the most invaluable part of it. So.
Thank you so much. Thank you for taking the time. I know you were super busy.
It's my pleasure. I'm glad we were able to make it work. And I'm very much looking forward to 9 days from now, Amber. I think that we're both excited.
Yes.
So
I'm really excited. And yes,
without a doubt.
I will be sharing. Now, will we be doing, do they do pictures before and after? Will that happen somewhere?
So we will, for sure.
Okay.
So you will have, there's always a round of photography that happens immediately before the procedure.
Okay.
And then at varying points in the aftercare period, pictures are usually taken more to chronicle the progress than anything else. But it's also fascinating to see the evolution. And I think that not to prolong the discussion too much, but what you see in the recovery room is going to be a little bit different than what you see at a week or two, which is going to be a little bit different than what you see at 6 weeks and then at 12 weeks. There is a little bit of a maturing process. So in general, for most women, it takes about 12 weeks for the majority of the settling to happen. But I look forward to seeing those after pictures at every step of the way.
And you know what? Maybe I'll even share them on social. I certainly will be sharing everything about my experience with everybody out there. If you've got questions that you want to ask me, I'm more than willing to talk about this. It's something that I'm very happy to be doing. I'm proud. I really trust my surgeon. And you know what? You brought up one other good point, which is do a little bit of research. There's a great site I saw, Bust Mob, that you join. It's very positive, but it was surprising to see, like right after, some people who just do implants, they can be really high. They can, all different things can happen. And I guess it's all part of the normal process. But sometimes it's better to know some of that stuff beforehand.
Always. So.
Well, thank you so much. I will see you.
It's my pleasure.
Dr. Kolker,
in a week and a half.
If people want to find you, what's the best way to find you?
So the website is Dr. Kolker, drkolker.com. And that's the best way to find all of the information about me and contact.
And if you just feel like doing like a little bit of like plastic surgery, oogling and eyeing, the before and afters on all of the procedures you do are phenomenal.
Thank you. Much appreciated.
Highly recommend. And of course, if you guys have any questions that you want to ask me, shoot them over. You can send them to me at hello@artbeautypodcast.com. You can also find us on Facebook, Instagram, and YouTube at Art Beauty Podcast. And as always, we will see you next Tuesday. Bye.
Fantastic. Bye.